To today's IFAM webinar. I'm Ron Ackerman. I direct the Institute for Public Health and Medicine. And before we get started today, I want to just remind everyone who is attending that we do encourage members in the listening audience to submit questions at any time throughout the presentation. To do this, simply click the Q&A button on the bottom of your Zoom screen. At the end of the presentation, we'll move through each of the questions with time permitting. Please don't use the chat function because we don't monitor that for questions. Today, I have the pleasure of introducing Drs. Abel Kho and Teresa Walnes, who will present on the topic of leveraging implementation science and informatics to improve cardiovascular care in real-world primary care settings. Dr. Kho is Professor of Medicine and Director of the Institute for Augmented Intelligence, as well as the IFAM Center for Health Information Partnerships. And Dr. Walnes is Assistant Professor of Medicine, Preventive Medicine, and Microbiology and Immunology. She's Associate Director for the Center for Health Information Partnerships. Without delay, I want to turn the microphone over and introduce Drs. Kho and Walnes to take us through today's presentation. Thank you.
Hey, good afternoon, everybody. All right. Good afternoon, everybody. It's really a pleasure to be here, and thank you, Ron, for inviting us. Since Ron has done such lovely introductions for us already, I think we'll just move on into the slides. It's okay with you, Abel. And just briefly mention that we have a few disclosures, but in the context of this webinar, I don't think any of them sort of bias the conversation we're going to have today. Very quickly, I wanted to kind of start out before we talk a little bit about data, about sort of framing the context for why we think this is sort of an exciting place to be. And many of you probably live in this space where you're actually thinking about, sort of how do we how generating evidence for understanding sort of how we improve cardiovascular care for people across the United States. And one of the interesting things about this is that much of it is generated through clinical trials and academic research settings that are very highly resourced. And a big question is often, how do you translate that into sort of real world care settings? And that's really the focus of the work we do, is thinking about what kinds of informatics and implementation science strategies can be used to adopt these interventions into primary care real world settings, and sort of how we use those tools to assess success of these programs. And so I hope that when we wrap up today, you'll have a little bit better sense of how we do that, and be able to think about how to do that in your own environment if you're interested. Just very, very quickly, I'd like to introduce EvidenceNOW. EvidenceNOW is actually one of probably the largest programs the Agency for Healthcare Research and Quality has ever run. It happened in 2015, and it was really focused on translating cardiovascular care measures into primary care settings using a tool called practice facilitation or practice coaching, which I'll talk a little bit more about. The interventions that we were focused on were focused on supporting the so-called Million Hearts ABCS measures, which was aspirin for ischemic vascular disease, effective blood pressure management, cholesterol management, and smoking cessation. And the goal of this, across the network, there were over 1,500 practices that were recruited to participate in this study. And again, making it kind of one of the largest sort of ever implemented in the United States for this kind of work. And locally, our program was Healthy Hearts in the Heartland. And I just would be clear, Abel was the principal investigator for this project, and my role was very much focused on operations and sort of implementing the study. And it was exciting and fun and difficult all at the same time. I just picture below is to show you the size of the team that it took. That was our kickoff meeting. And our team was actually even larger than that. But we recruited 226 small primary care practices across Illinois, Wisconsin, Indiana. And in this context, that also included many of our federally qualified health center partners. We had a relatively, what we think of as straightforward intervention, but our focus was to improve the million hearts measures using point of care strategies or care strategies that occurred when the patient was in the clinic, or population health management strategies, which meant that the clinic had to use data to sort of figure out how to manage care for their patients. And they were built on top of effective use of the electronic health record. And for those of you who don't know Abel and I well, pretty much all the work we do is focused around using electronic health records. So what's also very cool is to do this, I mean, this is hard work, and to do this, each practice was assigned a practice facilitator, or we think of them as practice coaches. And these folks are just like we think of your personal trainers, they're kind of a personal trainer for a primary care practice. So they go in and they help the practice develop capacity for change and quality improvement. The study timeline was pretty simple. The practices had a 12-month intervention phase working with the practice facilitator, and then they had a so-called 6-month sustainability phase where they got no practice facilitation, but it allowed us to see if they could maintain any change that was delivered through the facilitator. And finally, the outcomes were those ADCS measures, and they were collected via electronic health record reports. Now, there's a whole lot of other data we collected, but I'm going to focus primarily on that for what I talked about. And just in case you're interested, Jody Ciolino, lead authored a really lovely paper that describes the setup of the study. This is like, it was amazing because like in some ways after 3 years and 226 practice, an incredible amount of work, a lot of the study can be summed up in this one figure, which, and the analysis of this was that Steve Purcell in General Internal Medicine led the evaluation. And essentially what you're seeing here is the change over time of the quality measures for the study. And so it's from the top to bottom: aspirin, blood pressure, cholesterol, and smoking. And on the left-hand side, you can see where the practices on average started at baseline, and the 12-month time point in the middle, and the 18-month time point is on the far left. And I won't go into a lot of detail. I'll encourage you to take a look at the paper for that. But the bottom line is that we actually did see modest increase between baseline and 12 months for all the measures. But what was also really exciting was that we pretty much saw sustainment between month 12 and month 18, which said that maybe something else was happening. Maybe we had also affected some actual, change. In other words, when our facilitators left, the practices didn't stop doing what they were doing. And I'm very interested in practice facilitation as a strategy. One of the things I like to try to work on better is thinking about how we improve health for people. Health can be through medication, but improving health can also be simply through improving access to care, improving the quality of care. And so I was really interested in what those facilitators were doing. And so we had the straightforward hypothesis that, dosage would somehow be associated with success in the outcomes, right? And no. What we found was that dosage of practice facilitation, the amount of time the facilitators spent with the practice, had absolutely no bearing on the practice's success in changing outcomes in their quality measures. So before I go too much further, let me just just give you a little bit deeper dive into practice facilitation. What is it? Because I think that's a fancy word. Practice facilitation, also again, practice coaching, is essentially a kind of support service to support care quality improvement and change management. And it can be delivered by an individual or a team of individuals. But the point is that these folks have a lot of specialized skills that they bring to the table. They understand how to do change management. They understand process improvement. They have education that they can provide around the interventions. And they sort of bring all that, as well as project management skills, and they sort of bring all that to the table to support the practice. And you can do this support virtually, which is what we're doing now, or on site, or both. And AHRQ, again, is an incredible sort of advocate for practice facilitation. And the link at the bottom, if you're interested in understanding a little bit more about it, is an incredible, incredible resource for that work. So in terms of thinking about assessing practice facilitation effectiveness, I kind of went back to brass tacks and thought, well, where is the facilitator really acting? And the sort of top box is meant to sort of point that out. And practice facilitator actually acts on the practice. They work directly with the practice. And it's the practice that actually provides support and care for the patient. And so if we think about that, a little bit more narrowly, it's the practice and the sort of facilitator and their strategies that sort of act on the interventions that the practice it sort of engages in. And then it's those interventions and those change in interventions that result in the outcomes. And so I thought, well, if the facilitator work isn't sort of directly impacting outcomes, or at least the dosage isn't, maybe we should look at the intervention space, because that is what the facilitators directly act on. And so with that, we sort of thought, like, there are two kind of primary questions that I kind of wanted to address. And that is, first of all, what facilitation strategies are most effective? Like, you know, can we understand the things that make facilitation successful? And because in many cases, these practice facilitation projects are very hard to generalize from, and people have had a really hard time. I mean, because this is certainly not the first set of practice facilitation focused studies that have been done, but it's the evidence for what makes successful practice facilitation is not very robust yet. So we're trying to look for some strategies, and so the informatics comes in to think about how we could sort of look at strategies more generally, and then also compare strategies across other programs. Little plug here for a tool that we developed to help us do this. This work was done largely by Sam Ross, who's senior practice facilitator on our team, and Rick Shagnon, who is a data engineer in our team. But the idea here was that essentially we had roughly 27 facilitation strategies and 35 interventions that had to be tracked. And so FACETS, our facilitation activity and intervention tracking system, which maybe sadly is really we call the electronic health record for our practice facilitators, was a place where the practice facilitators not only documented their activities, but also sort of what was going on with the practice in terms of their interventions at 0, 12, and 18 months. So the nice thing about this system is that we actually had all the practice facilitation activity data and all the intervention data brought together in one space. And one of the things that might be important to note here is it's 27 facilitation strategies, a lot of strategies. And not every practice might get every strategy. So it was really clear from the get-go that it wouldn't be very easy for us to like try to associate one strategy, one specific with any particular intervention. So we really figured we needed to think a little bit differently about how we put these strategies together. And there was a group that was associated with EvidenceNOW that actually proposed this facilitation strategy framework, or spectrum as we started to call it. And it sort of focused on one hand where the facilitator is doing like all the work for the practice. You know, they're calling the EHR company, or they're setting up the report, they're building clinical, they're really doing for. And then there's a sort of a spectrum of activities all the way up to coaching, where the practice facilitator is just that. They're the coach. They are not the hands of what's happening. And in between that, the sort of the facilitating represents really kind of project management sorts of things, workflow adoption, consulting, providing expertise, and training, sort of like more hardcore education. And Jen Bannon, who is our practice facilitation lead in the Center for Health Information Partnerships, also nurse informaticist and sort of incredible resource for this kind of work. She led 4 senior facilitators that were across the group of facilitators that we had for H3 to basically take those 27 things and map them across the spectrum to see, first of all, to see if it made any sense. And this was, you know, we tried to conduct this is with, you know, in the grounds of study, the practice facilitators did this independently, came back, and then resolved any conflicts by sort of majority decision. And we determined that this top box, you can see that you see our strategies mapped to the sort of spectrum of activity types. We had activities in all different categories. Not perhaps surprisingly, given the kind of project, the training piece was very dominant because we had a lot of information that we had to communicate to our practices, but every category had something. And when we looked at like, okay, well, what was the representation? What was the spectrum of activities that our overall practices received? That's what you see on the bottom. And what you see out of 4,485 total activities that our practice facilitators implemented, the majority, or sort of like the largest bucket, was the education piece, followed not by coaching. But everything was represented. Again, there was a full spectrum, as it were, of activities delivered to our practices in H3. So that led us to sort of go, well, what was the individual practice getting? I mean, were we seeing a lot of differences in that? And that's what you see sort of on the top. The top is a sort of a histogram that presents each one of those lines as a practice. There's of the 226 practices, and we sort of just looked at this spectrum of activities they got. You can see in general, most practices got a little bit of everything. That was encouraging, but you can see some practices had very few activities. Down here, like this is actually less than 10 activities, while some had over 100 activities. And we thought, hey, maybe that's what we're going to see. The number of activities are going to tell us like how many are going to be associated with interventions. And so we looked like at how many interventions each practice had completed. And you can see that there's absolutely no relationship between the number of activities that the practice facilitators engaged in and the number of interventions that the practices succeeded at implementing. So we spent some time, and I want to highlight John Chang Yi and Nick Soulakis, who really helped think about how not only how to create this data, but how to think about different way of thinking about it. And so we actually, Nick is not only a deputy commissioner at CDPH, but he is also a really fantastic data scientist and epidemiologist. And so, you know, he suggested, well, maybe we should think a little bit about a more machine learning strategy, something where we're not just trying to do simple regression to understand this, but we're actually trying to think about multiple variables and how they work together. And so we ended up using something which is called hierarchical regression modeling, but I think of it more as a way of just developing a set of rules using some sort of a statistical science that help us sort of understand how, you know, if we look at the number of interventions completed, you know, can we develop a set of rules that helps us understand which practices and what they got led to the most interventions that implemented. So this slide is that tree. And I'm gonna start from the bottom and work up a little bit because I think it makes more sense. So the idea is if the interventions were the thing that we were using to sort of drive the modeling, across the bottom, roughly from sort of left to right, you can see that the segment on the far right, far left, completed on average no interventions, whereas the segment on the far left had 17. All right, so we were able to successfully use this model to sort of group the practices by how many interventions they were able to accomplish. Starting now from the top, we looked at sort of the first separator, and it was just sort of how much of that practice management they got, or how much of that project management support they got. So practices with lower levels of project management, ultimately, that was sort of the first dividing point, and they had fewer interventions that they were successful at, whereas practices with more of that sort of project management support seemed to do a little bit better in terms of implementing their interventions. If we look now down on the ones that were really successful with their interventions, coaching really mattered too. And you can see that practices that got a fairly high number of project management interventions combined with a high number of coaching interventions were actually successful, and they were able to sort of on average implement about 17 interventions. And that's about half of the interventions that we had available. So kind of said to us that, you know, actually coaching was really important. And in the absence of coaching, practices really struggled to actually make effective change happen. And this is sort of a summary. We wanted to say, well, how can we understand which practices were in which groups? I mean, perhaps, for instance, maybe it was all of our federally qualified health centers that ended up in this group because for some reason they were more receptive to coaching. And this eye chart, the take-home message from this is to say, actually, whether practices, it didn't matter what size or whether they were in a network or whether they were a federally qualified health center, they were pretty well all equally distributed across the segments, which was really encouraging because it said that generally speaking, the strategy was really good. And also there was a little bit of an outlier in that Wisconsin practices did sort into this segment. And we think that's because there was also a facilitator who's quite exceptional at coaching in that space. But to get back to that question of dosage, very quickly, if we looked at the segments, and again, we did not sort of train the model using this information, but what you'll see is that, again, the practices who got the most coaching and implemented the interventions also had the highest median number of visits from their practice facilitator and the most time spent with their practice facilitator. So we were also able to show that in the presence of coaching, we increased, or we have an association with an increased amount of time spent with the practice. Again, John Chang did the vast majority of the sort of analysis on this work. So I'm going to wrap up here, but just to say, coaching matters when you're thinking about going into a practice and trying to help them adopt an intervention. Make sure you've got a good coach there, and not someone who's just going to go in and do for them, but someone who's actually going to sort of work with them and help them build capacity for change, because that's associated with more time spent by the coach, as well as more visits from the coach. And just what's cool is this seems to work in a lot of different settings. It isn't just small practices or network practices. So we hope that, and we're going to look at this in future studies, but we really think that this is something that's a little bit more generalizable and a way for us to focus our activities. Just also, last but not least, we have some great facilitators in CHIP, and we look at them as a sort of community resource. They are amazing people and they do amazing work. And if anyone out there is thinking about a study like this and would either like to work with one of us or like to consult, we would absolutely love to work with you. So this is an example of one kind of real world setting, which is like working in a clinic. There are many kinds of real world settings to consider. And so for the next part of this talk, I'm going to hand it over to Abel, because he's going to talk to you about a community real world setting.
Before we go there, I wonder if there's 3 questions that came in that might be relevant for maybe while it's still fresh in people's mind. Do you want to just do those while we have maybe a few minutes? I don't know if I see one from Anthony Pick. I don't know if you can read those questions, or I can read them.
Sure. Sure. I mean, I can look at it. So Anthony Pick's question is like, maybe the practices that needed more interventions were starting off with worse processes in place. That's absolutely true. It is always, all these practices started with from very different places. And there's a lot, that's the whole conversation about dosage and what people need. I mean, some practices are super sufficient and don't need as much effort, right? So they're going to be successful regardless of what you do. And actually, that's one of the things that we're going to spend some more time on. So this is the first side of the machine learning model. Jen Chang and I are actually working on building the practice characteristics in so that we can start to understand the interplay of the relationship between the facilitator and the coach, the facilitator and the practice, and understand better some of the variables. And Jody has 2 questions in here. Can I define the coaching process? I will just say the personal trainer analogy is really good. In other words, the facilitator will go into the practice, do an assessment, try to understand their capabilities. And this was a tailored intervention strategy. So they will actually try to tailor things to what the practice knows how to do and kind of meet them where they're at. And so that's sort of how the process works. And then once they get started, they continue to meet with the practice and they continue to work with them in terms of the things that they're trying to tackle. And the practice has a huge impact on what they want to do too. So there's a sort of shared decision-making piece that goes hand in hand with that. And I'm happy to talk more if for folks who'd like more details. And Jody also asked, can what you learned here be generalizable? I do think so, but we have more to learn. In other words, part of the reason for creating that framework was so that we could ask other parts of the EvidenceNOW collaborative to map something and see if they saw similar results. We also have 2 more of these programs, Inspire, that's focused on unhealthy alcohol use, and Healthy Hearts for Michigan, which is focused on, is actually a smaller version of this one. So we're hoping to sort of test it again. So I would say at this point, generalizability, we have to test and see. And Dr. Spring asks, like, what kind of training do the coaches have? Actually, that's exciting. They have all sorts of training. We have a lot of nurses. We've had practice managers. We've had folks with psychology background, social workers make incredible practice coaches. But so they start from a variety of places. And then basically most of the time when you run one of these programs, you have to have a lead facilitator or someone with a fair amount of experience who then helps sort of set the stage for the education for the facilitators, helps them get trained up in the subject matter expertise. And often they get motivational interviewing training. They do a lot of hands-on and role-playing training. And then, like a lot of clinical care, it's experiential. We need to get them into practices. And we often will have them shadowed by a senior coach if they're brand new, so that they can have that experience while they're getting started. So I hope that kind of answered the questions. And thank you.
Thanks, Teresa.
Yeah.
I guess you can pass the screen back to me, and I'll.
Okay, I'm gonna
let me see
stop sharing, and it's all yours.
Okay, let me see if this works. Hold on. All right. Okay, can folks see that screen? And I'll enter the. Nope. Okay, can you see the screen? Okay.
Yes.
Yes.
Okay. All right. Great. Thanks. So thanks for that presentation, Teresa. That was a great summary. And you know, it reminded me actually that we still have this bottle of H3 wine that when the pandemic is, it's just coming to an end, hopefully for now, we can crack that open and celebrate. And we just actually got word today that one of the papers about strategies for generating electronic clinical quality measures from EHRs just has been accepted. So that's took us a long time, but that's finally in. So as Teresa mentioned, there are lots of different ways of doing implementation projects. And I'm going to focus today on just describing one that we're about 1.5 years into it. It's funded by NHLBI. And it's really been, it's a ton of fun. This has been sort of the culmination of work that we've, and a group that we've been building now for the past, 15 years. And so in many ways, the group that's come together around this is a lot like family. And in a lot of recent events, people have been incredibly supportive and helpful in supporting each other over the past few months and year. So the title of our group is called the Community Intervention to Reduce Cardiovascular Disease in Chicago, or Circle Chicago. That's our logo. We love taglines. And so this is all due to J.D. Smith, who came up with this beautiful tagline: "What's good for your heart is good for your soul." So J.D. not only is a great implementation scientist, but he has a future as an ad exec, I think, if this ever doesn't work out, which I think it will. So we're one of 7 different groups around the country that's funded as part of this Decipher initiative. And Decipher is really focused, it's an NHLBI effort that's focused on trying to reduce disparities in cardiovascular disease. And so these 7 groups with a coordinating center at UNC are focused on different aspects of cardiovascular health. There are 3 of us focused on high blood pressure. There's 1 focused on childhood asthma, 1 on smoking, that's UIC, the other site here in Chicago, and then 1 focused on mental health as it affects cardiovascular disease out of the Hopkins group. And we actually also have just gotten our sort of summary manuscript accepted for this Decipher Network in health services research. And so, hopefully that'll come out sometime soon, that people can read about all the different types of programs that are out there. Suffice to say, it's also been a very supportive group, and we're learning a lot from each other. And I think that there is a lot of overlap in our approaches, and also enough differences that I think there's much for us to learn. So what I was going to try to express today were just three points. One, I wanted people to be aware of the amazing work that's happening on the South Side for a group called Pastors for PCOR, or housed through an organization called Total Resources Community Development Organization. So I just want you guys to hear about that. I think it's an amazing thing. The second thing is that there's an opportunity for diversity supplements to this award. And I'll tell you a little bit about that. We'd really encourage people to apply for those under this same umbrella. And the last thing is an informatics sort of subtlety. And a lot of the work we talk about with disparities, we sometimes forget that there's a data side to it too. I think people recognize, I've heard about a digital divide. And I think there is some recent change in legislation that gives us an opportunity to bake in sort of digital health equity early on in projects like Circle Chicago. And I'll just give you a little bit of a flavor for that, so that maybe you can think about incorporating this into your work as well. So this project is, again, this is like family. Many of the people we've known for almost as long as I've been back here in Chicago. We all know J.D. Smith. He's an amazing implementation scientist. Dr. Paris Davis is a principal and lead and leader in Pastors for PCOR, helped sort of put this together, and also in Total Resources Community Development Organization. She's been an amazing partner. And then we have groups that we've worked with for many years at Alliance, Rush, Access, and of course, Stacy Lindau, who has been just a tremendous sort of celebrity, I would say, and amazing researcher and powerhouse and has been a great partner here too. Beth Lynch, I should note, just her along with Albert Wong just received a very large award to address disparities in chronic disease writ large in Chicago. And so we're excited to continue to work with her, both in this capacity as well as with our future leadership role there. And so, and then Danny Lazar is funny because we're in this Zoom thing world. And one day we were on a Zoom call and she says, I think I recognize your background because I was sitting on the porch. And then so, a few minutes later, sure enough, she walks by because apparently she just lives up the street from me. So I don't know how she recognized the background, but she did. So it's kind of really been a lot of fun. We have a tremendous additional team. Neil Jordan here, Teresa, as you know, Jakob Tedla, who's now at Vanderbilt and provides a lot of biostatistical support. Megan McHugh on a lot of our qualitative evaluations. Nami Kandula, one of our colleagues here in GIM, and she's an expert in community engagement. And Rebecca Johnson, who is also here at Northwestern, but now is an independent researcher working very closely with the Pastors for PCOR group. And I'll share with you some of her work that she's done. We are lucky to be here in Chicago. We've got a lot of amazing consultants. Gautam Rao is over at Case Western, but the AMA is here in Chicago. And AMA was a partner on H3. So they are committed to improving blood pressure measurement and control. And so Mike Raycotts is one of the more energetic people you'll ever meet in the blood pressure world. And he's, really been a super advisor for us. Greg Aarons, implementation science expert. Nick Martin brings the AHA presence to the fold. Jen McLarsky, part of the group at University of Chicago. Hendrix Brown, obviously an implementation science expert internationally. Mark Huffman, who is here now at WashU, and Quentin Yeomans fills out our cardiology expertise. And they've been providing us a lot of guidance about how we not only do better blood pressure control, but how we do it in a responsible way within the community. And we're really thrilled to have them. Ami Ashtega, could not find a picture of him to save my life. He doesn't exist on the internet, but is an expert at CDC and blood pressure measurement, especially with things like NHANES and Burfus. And so he's given us a lot of guidance on what types of blood pressure cuffs and how do we do this effectively. So that's been great. But each of these individuals is part of larger organizations. And so we have these large community health center networks, Alliance Chicago, Access Community Health. In addition, we have data support from Capricorn, which provides a sort of like population level blood pressure measurement. NowPow was founded out of work on Community RX by Stacy Lindow. It was recently acquired by Unitas out of New York. And they've still committed to continue to work with us on this project. And they're really focused on trying to, they built a platform that allows us to identify the community resources that are most relevant for self-management of chronic diseases. And so that's something that we think is going to be really important as we try to create a more holistic approach to supporting people in controlling their blood pressure. And then Crowd is a group of experts in engaging or having built a capacity around community health workers. And so they're going to be, I think, also very important as we roll this intervention out to the south side. And that's where we're focused. And so if anyone has seen any maps of disease burden in Chicago, it's been pretty obvious where it is for most or many diseases. And so this map is from the Chicago Health Atlas. It's based on administrative data or estimates from surveys rather from Burfus. And as you can see, there's a high prevalence of hypertension in the south side. This is our study area. On the right is a map that shows the geographic location of some of the Alliance and Access clinics, as well as the churches that are part of Pastors for PCOR. So you can see there's a really tight overlap between both the high prevalence blood pressure areas, as well as the churches or faith-based organizations and the clinics that serve that area. Now, it's not comprehensive, but we think it's reasonable coverage that would allow us to conduct a study in the out 4 years of this type of UG3, UH3 mechanism. And why is it so relevant? Well, Chicago is burdened with one of the largest life expectancy gaps in the US. It's profound. It's 30 years difference between people living in the south side, like that area we just described, and those living just a few miles away here in a neighborhood more like where our health center is. Northwestern is. And that's for many reasons, but it's really long-standing. It's rooted in centuries of systemic racism, economic exploitation, mistrust with the healthcare system, all I think warranted. And so, the approach that we've taken in Circle is that in order to make a difference, I mean, it really is so important to bring community members at every step along the way, including at inception in the ideas. And we've been very lucky because, and this is one of the main points, is Pastors for PCOR has been around now from early days within our Capricorn network and PCORI. And what they've done is something that's kind of, I think, extraordinary. And I just want to share with you a little bit about how they've designed this, because it sort of flips research on its head, the research paradigm. The first thing that they've done is they've created an environment that in the community that is ready for research. And what that means is that, and I'll show you in the following slides, they've created an infrastructure and trained individuals and a community connection that allows community to engage in research as any other research could be done in any other community. They've also then been able to identify what are the priority research areas for the community itself. And therefore, instead of researchers coming to the community, they know to seek out or to identify which community, or rather which researchers align with their priorities. And I think that's a really exciting sort of approach that, again, is different than sort of researcher coming to you. It's them sort of deciding from the onset. And what does that look like? So what they've established is a research ministry network, and this is organized as follows. There's an a Pastors for PCOR advisory board, which is made up of both community members, but also from external experts. There's an active and an engaged group of faith-based community leaders. These could be pastors, could be bishops like Bishop Gordon, and these are leaders within the community who are able to sort of look up and understand a sort of big picture strategy, and also identify within the community individuals who are activated, engaged, and want to also be leaders in this research effort. And so what they created and have trained over the past several years is a group of Pastors for PCOR ambassadors, research ambassadors. And what this means is that you now have faith-based community leaders and ambassadors who have been trained in the responsible conduct of research, just like we are. So there's city training, understand IRBs, there's a federal-wide assurance in place. So all that blocking and tackling that's necessary to be involved in NIH-funded research, that is being done. It's already taken care of, and you have a trained group of individuals who can do that, who live within the community. And because they're part of the community, then you have the ability to engage peers, so the congregations themselves. And what that leads to is a very ripe, that's very rich environment for the conduct of the responsible conduct of research that is built from within the community itself. So one of the things we'd like to see in Circle is that this is, in many ways, blood pressure control is self-contained. It is driven from within the community, owned by the community. And we think if given the right set of training and tools, I think there's no reason that a map of Chicago should look like an even map. There should be those disparities should go away. The other thing that we mentioned was that it's really important that there be priorities that the community has identified itself, and then can reach back out to researchers. And if we're willing to listen, then there's an opportunity to partner. And so this is work that Rebecca Johnson did with Pastors for PCOR, where she conducted a community health survey in a number of these churches or faith-based organizations in the South Side. And these are pretty representative of sort of the population that we're focused on here in Circle. Again, it's a predominantly African-American, a diversity of individuals responded, although majority were women. But the survey was both developed and administered by the previously mentioned research ministry ambassadors as part of their training to become part of this ministry. the size of the parishes or churches or faith-based organizations was quite diverse, ranging from very large ones, but the majority actually were relatively small in size, with congregations less than 500. So, a smaller group of individuals. Bottom line, though, is that, and Rebecca published this 2 years ago, was that hypertension emerged as the highest priority cardiovascular concern in 2016 and 2018. And this was something that sort of like encouraged us then to partner together to go after this particular NHLBI award. So I think in large part it was sort of their priority, and we just happened to be partners that had already been working for many years with them, and so it seemed like a good fit to partner together and go after this type of award. That has carried through. So within the Circle community, we have a number of work groups. There's a community engagement work group, obviously led in large part by Pastor Igor and the community that they pulled together. But there's also representation from all of the from community members in each of the other working groups: facilitation that we've heard about from Teresa, the intervention work group, design analysis, and informatics. And so, and on the informatics side, we'll get to that in a second. But that's an important piece where I think community engagement we don't always think about, but it's especially relevant today because there's an opportunity today to do better. So the way the study is designed, we are trying to adapt the Kaiser Permanente blood pressure control bundle into this community in the south side of Chicago. Now, that may seem like a really strange choice because you're like, well, Kaiser Permanente, it's a big integrated health system, payer, why would you do that? But it does turn out that there have been some adaptations of the bundle, which includes a registry, audit and feedback, simplified treatment regimens, and blood pressure measuring and monitoring, and then a health IT component. That parts of those have been adapted to churches in the past. And in fact, when we go through the literature, there was actually a pretty effective adaptation of the Kaiser bundle to a set of federally qualified health centers in San Francisco, and that was published in 2018. And so we took some, we were reassured that we could go ahead and do something similar. And so this is sort of our a chart that shows how we think that these adaptations would likely work within Circle Chicago. So still a hypertension registry, control reports, but instead of nurse blood pressure checks or medical assistant, we might have community health workers, or even home blood pressure monitoring is something that's on the table now. But the single dose combination therapy is still one of the foundational pieces that we're likely to push forward as part of Circle. We're using the EPIS framework for our dynamic adaptation, and you can see here sort of the highly intertwined nature of this work. But again, I think one thing that's key is that right now we're in the exploration and preparation phase. We just got off a call with NHLBI about the implementation part. And what's clear is that real world studies like this in the community have to be very flexible because your ability to randomize and control and there's a balance between that and a person's autonomy. And so we're still working through exactly how that would be, but it is right now the balance is always going to tip towards autonomy of the individual. And so we're going to make sure that where possible, we create wraparound capacity so that people can still make the choices they would like to make. And then from a data capture standpoint, we're able to do that in a seamless way behind the scenes. This is the current recruitment process that has been sort of vetted through our faith-based organizations. And as you can see here, we think that a large part of this will be engaging people through the churches, but also through CHCs. So that we can go ahead and introduce individuals for whom this is already a priority about this hypertension initiative, and then get the word out through the existing process in place. So one thing that Pastors for PCOR also has in place is a very large outreach arm, including actually within the Tridestone Church there, an actual recording studio. So there's many different ways of reaching out to the community beyond just sort of traditional methods. And so we're excited to sort of partner with them on some of these outreach approaches. There's a sort of number of educational steps once people who do express interest, we're able to provide for them. And then once they are expressed interest and have consented, then at that point in time, we can then refer them into the community health centers, given the importance of medication therapy for control of blood pressure, as well as then get consent so we can start enrolling them in the registry so we can capture longitudinal information about what happens to them and their health conditions. So the second point I wanted to talk about was really on the informatics side. You know, we do a lot of work in this space, and as Teresa mentioned, for the past 15 years, we've always worked with electronic health records. But I wanted you to be aware that in 2016, there was a piece of legislation called the 21st Century Cures Act. And like many sort of pieces of legislation, it was on a timeline, a very sort of methodical timeline that would roll out. But this year in 2022, there's an interesting sort of development, which is that as of the end of this year, all certified electronic health records are required to make available easy access for patients to directly get their own digital health data from electronic health records. And then they can either use it for their own purposes, or increasingly there is a sort of world out there that's building applications for patients to be able to take that information and interpret it and use it, or even bequest it to others for responsible research. And so one of our goals in this project is from day one is to ensure that patients who are enrolled in the study have direct access to their own information in whatever form they would like. It doesn't have to be on a mobile device. It could be on a home computer or even on paper. And so we hope to ensure that anybody who wants to have their information can do so. And that's a really different model than traditionally we've conducted research in the past, whereby the health systems in essence are stewards of the data, and we as researchers access it on patients who may never even know that their information is being used for research. It's just the nature of the way we've set things up today. And so here is a chance, we think, to go ahead and change that paradigm. Again, shift the locus of control of people's own data back to the person. Whereas we as researchers, much like this community engagement, are bequested with the data to then do research on that, as opposed to like us as researchers having it and then, sort of that doesn't seem to make a whole lot of sense from a locus of control standpoint. The way we're doing this is rather than rebuild something from scratch, we've chosen to partner up with this group out of UCSF, which has also been funded in the past by NHLBI, and they've created a platform that allows that is been able to connect securely to different electronic health records, including Epic. And so this method we think is exciting because again, it allows us to authenticate based on a person's credentials, consent, and then they receive the information and then can make that available to us as researchers to then conduct the rest of the study. And so that's the approach that we're taking for everybody who registers or gets enrolled in the study. E-consent, secure authorization. You receive the information. We as a researcher are partners with you. We can then work with that data to conduct the analyses as appropriate for the study. So again, an opportunity. I think everyone should be able to do this as of end of this year. And so we think that over time, this approach to accessing data for research will grow. It won't be the biggest. It'll always still be typically institution-based. But over time, we see likely that there'll be a larger and larger number of patients who own their data, for which we have to partner with them to conduct research. Dr. Davis and JD and I, we had recently submitted a manuscript, and JD and Paris were able to give a presentation. And this is just one of the quotes from that paper that you can read there. I think the key here is that different environments need different implementation strategies, and again, how do you do that? You have to have it shaped by the community. The last point I want to make was really just a call. It's that people are what drive everything. And if you have an imbalanced workforce, you're likely going to have a persistence of disparities and inequity. And diversity supplements are actually available to almost many different NIH institutes. We've been strongly encouraged as part of the Decipher Network to solicit applicants for this mechanism. I had a recent call with Paul Cotton, who also is from Chicago, by the way, and he's incredibly encouraging. And the things he described about the program are extraordinary. I had no idea this of all the details. There is a rolling submission that goes from, I think, roughly November to March. But anybody from a high school student all the way to an assistant professor is eligible for this type of diversity supplement. It has to be attached to a parent award. In this case, it would be this Circle Chicago. But we have one applicant already who's an assistant professor who is applying for this. But we'd really love to get as many people interested in this mechanism as possible. And we'll do our best to help you as you submit this, because again, we think that people matter the most of any project. And if we can expand the diversity of the workforce, that's going to be really the most important thing we can do, probably the strongest legacy of a program like this. So with that, I'd just like to close and just to thank many people who have made this possible. It's amazing to think that we ever stood that close, but hopefully those days will come back again. And then there's a plug on the bottom right there is just up the street from Tridestone Parish. Our Baptist church is a rainbow cone. So anyway, it goes to the south side, make sure you stop by Rainbow Cone. It's worth a visit. So with that, I think we'll stop and take any questions. I haven't looked at the chat, so I'll take a look at that now. Let's see how we do this. Oops.
Abel, are you using the Q&A? There's a few questions there.
Yeah, I'm just opening it now. Okay, yeah, right. I see one from Anthony Pick. I think that's a relevant one. Consider ARB diuretic combination. Yes. So we actually, this has been really interesting. That the science behind this combination therapy, it does seem to keep evolving a little bit. So it seems, and this is actually what Anthony Pick described there. It appears that the advisory group that we've spoken to has said the same thing as Anthony has pointed out here. And I think that the lean-to right now is to go ARB diuretic as our combination therapy of choice for that subtle reason that there is a slightly better tolerance. And so the one thing that we have to work out mechanically is that there's different availability. And so we're right now in the process of inventorying the available combination therapies and cost at the different clinics, because this is a real world implementation. So all these sort of practical issues are the ones that get you if you don't figure it out. So yes, spot on, you predicted it. We're actually going ARB diuretic probably. Jody talked about preparing the community. My question is, what is the preparation that goes into the researchers to be sure that trust is never broken once at pressure? So, this is, I don't even know how to answer that exactly, because there's no like simple pithy answer. I will say that, somebody told me once that actually, the secret to providing good care is just to care. And I think the same applies to the kind of work we do here. If you do care about the people you work with, it comes out. If you care just about yourself, it'll come out too. So I do think that there is like a personality type that, like I said, there's probably principles people could live by, but those are sort of baked in by the time you get to a certain age. So, but if you are if you're a trustworthy person in the rest of parts of your life, you're likely to be trustworthy when it comes to this kind of work. But obviously the other big component is, I think, making sure that there's constant engagement, because even if you're always having those conversations, it's a lot harder to get off the rails. And so it's designed into our program, is that there's engagement in all the different work groups, and that certainly seems to help too. Is disability considered within the diversity paradigm? So I'll mention a slightly different project. Disability, absolutely. Actually, I don't know if maybe Tara Lagu actually is one of the center directors here, and has really been thinking a lot about how are we addressing disability as one of the parts of diversity. It isn't actually, I don't believe it is considered right now by the funders, but it should be. And I think one of the Tara, I would refer people to Tara Lagu for her thinking about that. She really is the expert in that area. Non asked, is the program open to continuing expansion? What's the next project for this group? You know, there's definitely capacity issues in terms of how much people can take on. For, I guess everybody's probably a little bit buried, but for purposes of this particular trial, the only way we'll be able to expand is by adding people, and that's where the diversity supplements are so important, or other supplements. And so we have a number of faculty who are applying for their K awards under this mechanism or associated with this mechanism, as well as the diversity supplements. And that's really the opportunity, I think, to expand it meaningfully with resources, because you know, it's if you don't have resources, it's hard to make things move. And Anthony Wong, has digital divide been a huge barrier for community to access health in Circle? I think it's just one component. If you talk to Total Resources Community Development Organization, they call themselves Total Resources because they do everything from food pantry to census, transportation. There's oftentimes a lot more of these other issues which I think are bigger challenges. When we first engaged with Pastors for PCOR several years ago, we did work through some of the sort of fundamentals like cable internet access, and is there a desktop in the church that you can use to connect? Those were relatively easier things to resolve, but some of the other continuous issues around, like, how do I get to a place, and how do I make sure that, you know, there's the appropriate, you know, people I care for are taken care of from a, you know, housing and food standpoint. That those are definitely, I think, much more challenging issues that people you know, have to work through. And then I think Lisa mentioned, sorry, it's a longer one. How's the approach to helping determinants to inform strategies? I don't know which may need. I see which may be needed to address barriers change as you move into more communities. You know, what we realized is that, you know, a lot of times we do social determinants at the community level, but everybody is really different. And so the things that you get from, like, geospatial analyses, for example, you get some basic ideas. It's yet to be clear that that always correlates with what's on the ground, especially in a diversity like Chicago. And so I don't think there's any substitute, if you can get it, in getting determinants directly from the individual, as opposed to inferring it or imputing it from other data sources. So that's just been an observation we've seen over the years. And I'm a big fan of geospatial analyses. I just, you know, think it doesn't always apply to each individual. Then Lisa, I apologize. I think I may have totally gotten your question totally wrong. And I can't read back the final question now. So you may have to email me that one later.
Well, we are at the top of the hour, so I really want to thank both of you for coming to present today. It's been a wonderful presentation, obviously very engaging, lots of questions, and people are very excited in your work. So I'd encourage folks in the audience, if you have additional questions or interested in the work that Abel and Teresa do, or that's being supported by the Center for Health Information Partnerships, or I.AIM, to reach out directly to them. This has been just absolutely wonderful, and thank you both today for taking the time to share your work with us.
Great. Thanks, Ron. Appreciate it.